Welcome to the role of the radiologist in the multidisciplinary management of bronchiectasis. I'm Patrick Flume. I'm a pulmonary physician at the Medical University of South Carolina in Charleston.
And I'm Mary Salvatore, a thoracic radiologist at Columbia University Irving Medical Center in New York City.
Our objectives today is to talk about the radiologic features of bronchiectasis and to differentiate those various forms of bronchiectasis that we see in high-resolution CT scans and help understand the role of the radiologist in the care of these patients with bronchiectasis. In this program, we'll talk briefly about what we mean by bronchiectasis, go over how imaging helps understand the etiology or potential etiology of their condition. How does imaging help with treatment decisions? What is the role of imaging during and after treatment? And then close with a discussion of future directions for imaging in the diagnosis and treatment of bronchiectasis. So let's start with a typical patient. This is an actual patient that we provided care for in Charleston. At the time, she was 61 years old, and she had a daily cough that was productive of yellowish green sputum. And her history was one of frequent exacerbations for which she would be treated with antibiotics in the last year. On examination, she had diffuse bronchi with squeaks. There was no digital clubbing. And on pulmonary function testing, she had moderate obstruction with an FEV1 of 62% of predicted.
The chest x-ray showed us that there were some abnormalities, but I couldn't have talked to you about the pattern radiographically. Looking at the CT scan of the chest, we have much more information. We can see that the areas of bronchiectasis, mucoid impaction, wall thickening, and tree and bud opacities are located in the anterior lungs, in the right middle lobe, and in the lingula. This is a very characteristic appearance of MAI infection within the lung parenchyma in an older female patient. And we call this Lady Windermere syndrome. For the definition of bronchiectasis is irreversible dilatation of the bronchus bigger than its accompanying artery, as we see in this picture. We see what's called the Signet Ring sign, where we have the tiny pulmonary artery and the bronchus that's accompanying it has become bigger in size than it. So this is mild cylindrical bronchiectasis. It occurs not infrequently, 566 people per 100,000 in the population, and the prevalence is increasing over the last few years, after the last 10 years. The ICD-10 diagnostic code is J47.9. There are multiple types of bronchiectasis which describe the morphology of the bronchi themselves. The mildest type of bronchiectasis we think about is cylindrical bronchiectasis, where the bronchus is dilated bigger than its accompanying vessel. The next worst type of bronchiectasis is varicoid bronchiectasis, where there's an undulating contour of the bronchi, as we see in the central picture. And the worst type of bronchiectasis is cystic bronchiectasis, where it looks like a cluster of grapes. It's said that if you do a VQ scan on these patients, that there'll be no perfusion to the areas of cystic bronchiectasis, so they're not participating in oxygen exchange. Lynn Reed was one of the earliest people to describe bronchiectasis. She did cadaver dissections, and I think the anatomy is helpful to review. The airways branch from the trachea to the periphery of the lung 26 times, and the conducting airways that are not involved in oxygen exchange branch 16 times, and those are the airways that she studied. She explained that in cylindrical bronchiectasis, you had 16 branches, like they show in the microscopic sections, but some of the branches were occluded with mucus, so macroscopically, you couldn't see all the branches. What happens in varicose bronchiectasis, she explained that there is now fibrosis of those mucoid impaction branches, and so there are fewer branches on microscopic imaging. And this is further truncated as you go down to cystic or saccular bronchiectasis, where there are much fewer branches. There are bronchiectasis that are intrinsic diseases of the bronchi themselves. In this case, the bronchiectasis, the traction bronchiolectasis, is due to something outside of the bronchi pulling the bronchus over, a type of traction bronchiolectasis, which is slightly different than intrinsic bronchiectasis, both giving you a dilated bronchus, though.
So how does imaging help in determining the etiology of bronchiectasis, which is really one of our first questions we try to tackle when we meet a patient with a new diagnosis?
When performing a CT scan of the chest for the identification of bronchiectasis, it's important to not use contrast. Whenever a patient receives contrast, they feel warm all over, and that makes them feel anxious and more tachypnic. And breathing quickly is the worst enemy of a chest CT scan. We want to use thin slices, less than 1.5 millimeter in thickness. We want to do it at full inspiratory effort. And then on the first CT scan, we can do expiratory images to see if there's air trapping. I'd like to just review the anatomy of the airways, because part of the report in radiology is going to say which bronchus is involved or which bronchi are involved. In the right upper lobe, there's an anterior bronchus and a posterior bronchus, and coming from the top is an apical bronchus. It looks like a goldfish cracker to me. Um, in the right middle lobe, we have medial and lateral bronchi, which is helpful to remember with the initials of the right middle lobe, begin with an M and an L, just like medial and lateral. When I think of the right lower lobe bronchi, they're kind of like a compass. There's the anterior branch like north, posterior like south, medial like east, and lateral like west, and coming up from the middle is superior. So there are 10 branches of the right bronchi. On the left side, everything is more truncated because of the heart occupying space. So the left upper lobe bronchus has an anterior, but now the apical and posterior divisions are joined together. Instead of a medial and lateral, the lingula has a superior and inferior. And in the left lower lobe, instead of having 5 branches, the anterior and medial are now joined together. I remember that like AM, like a clock, with the anterior and medial being joined together.
Our second patient example is a 62-year-old female. She presented with a bit of hemoptysis, and this led to the performance of a CT scan of the chest. In her history, she had pneumonia early in life at the age of 12 years and described symptoms of bronchitis that persisted throughout a pregnancy. On the CT chest, there were very focal findings in that left lower lobe, and on bronchoscopy, we were able to define Pseudomonas aeruginosa present in the BAL. So one of the key factors that we think about in the evaluation of our patient and trying to understand the etiology is, what does the nature of disease look like on imaging, with a big difference between those who have focal disease and those who have more diffuse findings. So in those patients who have more focal bronchiectasis, like the patient we just defined, we sometimes see them in cases where there is post-infection. And this was really one of the earlier etiologies long ago, where there was a bad viral infection or bacterial infection. But also we can see it in patients who have a bad mycobacterial infection, particularly in the patients we see from Asia, where there is more endemic tuberculosis. But we can also see it in areas where there is focal airway obstruction, like from a foreign body or a stricture in the bronchus, an endobronchial mass, or some atresia. But if they have diffuse disease, location can be helpful in terms of trying to define the etiology of disease, comparing central bronchiectasis to more peripheral disease.
So we can think about bronchiectasis occurring in we talked about conducting airways that Lynn Reed described. She said there are 16 of them. When bronchiectasis occurs in the central bronchi close to the trachea, there's a narrow differential diagnosis that includes um, Munyar-Kuhn's, allergic bronchopulmonary aspergillosis, and Williams-Campbell. Munyar-Kuhn's is tracheobronchomegaly, and the trachea should measure more than 3 centimeters in order to make this diagnosis, which is exceedingly uncommon. In addition to the dilated trachea and dilated bronchi, the patient develops bronchiectasis downstream from recurrent infections, and they get tracheal and bronchial diverticula, which help narrow down the differential. Central bronchiectasis, allergic bronchopulmonary aspergillosis, causes dilatation of the first to the fourth branch of the bronchi, and it gives you what is a hand and glove appearance, where the hand is the mucus and the glove is the dilated airways. Over time, the mucus within the bronchus becomes desiccated and can become calcified. It has a very characteristic appearance on imaging, usually upper lobe predominant and associated with asthma. Williams-Campbell is a relatively rare disease, but when you see it, it's an ant mini. And instead of the first to the fourth branches of the bronchi being dilated, the fourth through the eighth branches of the bronchi become dilated, like in this case. Like you can see that the central um, bronchi are normal in size, the middle bronchi are dilated, and the peripheral bronchi are normal. The key to imaging with a patient like this is to ask them to breathe out. If these bronchi collapse due to lack of cartilage, then it's characteristic of Williams-Campbell. When a radiologist sees a CAT scan and a patient has diffuse bronchial dilatation, the next question we should ask ourselves, is it predominantly in the upper lungs or the lower lungs? Upper lung predominant bronchiectasis includes sarcoidosis, cystic fibrosis, and tuberculosis. Sarcoidosis in the upper lungs is usually type 4 sarcoidosis, where the bronchi become dilated, particularly in the posterior aspect of the lungs. Cystic fibrosis was described by a Dr. Dorothy Anderson at Columbia, where she noticed that babies that had salty skin were developing bronchiectasis and dying. It's an upper lung predominant type of bronchiectasis. Tuberculosis, like sarcoidosis, causes dilatation of the posterior upper lung bronchi. In a characteristic appearance, might also see tree and bud opacities that would help with the diagnosis. In contrast to a patient having upper lobe predominant bronchiectasis, if they have lower lung predominant bronchiectasis, our differential includes aspiration, especially if we see mucus within the lower lobe bronchi, or if the patient has a large esophagus, a dilated esophagus with an air fluid level. As in the patient that we showed earlier, non-tuberculosis mycobacterial infection is very common, maybe 3 times a day. In a pile of 30 CT scans, I'll see this diagnosis of MAI with dilated bronchi, characteristically in the right middle lobe and the lingula, and more common in females. And then desmodal cilia. If I see a lower lobe predominant bronchiectasis in a younger patient that gives a history of recurrent pneumonia, I think about desmodal cilia. If they have a dextrocardia, I think about Cartageners. But there are many variants of desmodal cilia that the clinician will be able to be more specific about. Here's another example of MAI, Lady Windermere's disease, 2 examples where we see the dilated bronchi. Sometimes they can be in the lower lobes too, but they usually involve the right middle lobe and the lingula. Here's another example of desmodal cilia. So a lower lung predominant bronchiectasis, we see the dilated bronchi. They are thick-walled. They have mucoid impaction and tree and bud opacities. And this is very characteristic of desmodal cilia, especially if the patient is younger in age. We talk a lot about mosaic attenuation and air trapping. We should use the term mosaic attenuation only on an inspiratory CT scan. What it means is that there's heterogeneity. So there's areas that are low density and there's areas that are high density. And the key thing is to decide what is causing the high and low density areas. So as a radiologist, we can look at the areas that are darker in color. And if the vessels are smaller in the areas that are darker, then we know that the dark area is the diseased area. In contrast, if the vessels are equal in the low density areas and the high density areas, then what we're seeing is ground glass opacity and not a disease of the dark area. The next thing we do if we think that it's a disease of the dark area is to get an expiratory CT scan. If the findings become more obvious to us, then it is air trapping, small airways disease. And we can say that there's air trapping. So we use the term mosaic on inspiratory CT scans. We use the term air trapping on expiratory CT scans. If the picture doesn't change much with expiration, pulmonary artery hypertension should be in our differential as to the reason that the patient has mosaic attenuation.
So how can imaging help in determining treatment of bronchiectasis? When we're treating our patients, we have a number of goals. First and foremost is to relieve the symptoms that led to that diagnosis. Oftentimes that is cough, productive of sputum, but may also be associated with nonspecific symptoms like fatigue, fevers, or night sweats. We'd like to prevent progression of disease and then prevent complications of the disease, something that we call exacerbations. So what is a pulmonary exacerbation? In general, it's a worsening of their day-to-day symptoms. So they live with this daily cough and sputum production, but now there is some clinical worsening that we can attribute to the underlying condition. We have a definition that we use in the research community, but it's actually pretty helpful from a clinician standpoint as well. So when a person with known bronchiectasis has deterioration in 3 or more of these key symptoms, but key to this is that it's been present for at least 48 hours. So we're not responding at the instance of symptoms, but we're also not necessarily waiting for them to persist for days and days. So generally there can be an increase in cough or a change in the severity of the cough. The sputum volume or its consistency may change. The color, so suggesting greater chance of infection and inflammation. If they're more breathless or have exercise intolerance, fatigue, and certainly if they have any blood ranging from scant to more significant hemoptysis. The other key aspect of the research definition is that there also was a change in therapy. Typically, those might be antibiotics. So a very important statement to make is that we don't have any medications or therapies that are approved by regulatory authorities for the indication of bronchiectasis. And the exception to that is cystic fibrosis. And what we are treating in those patients is their bronchiectasis. So if we can, we will treat the underlying cause of disease. So that's why we invest time trying to determine the etiology, because there might be specific therapies that would be appropriate for their condition. We treat the comorbid conditions. Very often, these patients will have symptoms of esophageal reflux that contribute to aspiration, as an example. And then we want to target the essential aspects of the pathophysiology of bronchiectasis. So historically, we have talked about the pathophysiology of bronchiectasis as a, a cycle of events. Think of it like dominoes falling one after the other, where you may have abnormal mucociliary clearance, which causes stasis of mucus that becomes a ripe environment for bacterial infection. When you have persistent infection, there's an inflammatory response. This tends to be primarily neutrophils. The weapons that these neutrophils use are also toxic to normal epithelium. So these elastases and other enzymes are contributing to the inflammation and the destruction and distortion of the airway, which then further complicates clearance. We've come to realize that every one of these steps actually contributes to the others. So for example, if you have an inflammatory response to infection, this inflammatory material actually contributes to the tenacity of this mucus, which makes it more difficult to clear. And that persistence of inflammation is not only causing injury to the airways, it's creating an environment that is actually promoting persistence of infection. The infection itself can cause injury to the airways themselves. So it's really more of a vortex of consequences. And so we'd like to be able to target these different aspects of the pathophysiology of disease. So we have a number of options that we use. This does not mean that every one of these is appropriate for all of our patients. Job one for many of them are airway clearance therapies. These are a series of breathing techniques or devices with the purpose of trying to enhance clearance of mucus that may be retained in the airways. We will use hypertonic saline, nebulizing this to try to hydrate the secretions or promote cough. Chronic macrolides. So although these are antibiotics, they are purported to also have anti-inflammatory properties. We will sometimes use suppressive antibiotics for specific pathogens. They may not eradicate the infection, but they can suppress it to try to prevent these events. In appropriate patients, inhaled bronchodilators or corticosteroids um, may be beneficial. So how do we think about imaging and guiding us for these therapeutic options? So here I talked about airway clearance therapies and the use of hypertonic saline to hydrate these secretions and make them easier to clear. What we see on imaging is when there is increased mucus plugging or an increase in the airway wall thickness. It doesn't mean that the airway wall itself is thicker necessarily, that it may be that there is increased phlegm, this mucus and other material which is retained in the airway that just gives it the appearance of increased wall thickness. Those are patients in whom therapies like airway clearance and hypertonic saline may be beneficial. The challenge when we use hypertonic saline is it can be irritating to the airways. So in those patients who have asthmatic features, they may not tolerate that therapy very well. In patients who there is concern about infection, and so in this example that had been shown earlier where there is great concern about mycobacteria, but we also may find other bacteria such as Pseudomonas in those patients. So it's important to be getting cultures in these patients. In patients who have frequent exacerbations, chronic macrolides such as azithromycin have been demonstrated to reduce the frequency of those events. Having said that, we would not want to use monotherapy with a macrolide in a patient who is known to have mycobacteria present in the airways because we don't want to select out a resistant version of that organism. So it's critical to know what the microbiology might be. If they have Pseudomonas, that's a group in which the macrolides have been demonstrated to be beneficial to reduce events, but it also might be a group in whom inhaled antibiotics might be useful. And then in the case where we might be suspicious of allergic bronchopulmonary aspergillosis, again, a case that was presented earlier, in these cases, although it is a fungus, which is the culprit, what's happening is they're having an allergic response to this, which we can demonstrate with marked elevations of IgE, often have eosinophilia. They will have antibodies against aspergillus, and we treat them as an initial method of therapy to treat it much like asthma. So bronchodilators and corticosteroids would be appropriate. And then in some of these patients, using some of the more advanced therapies for asthma or even antifungal suppression might be appropriate. What's the role for subsequent imaging? Obviously, we need the initial image to make the diagnosis, but what about follow-up imaging? So there are certain reasons why one might do subsequent imaging. Obviously, one is surveillance, looking for evidence of progression of disease. This is not to be a discussion about how we treat mycobacterial infection, but not everybody needs to be treated. You do want to treat those patients in whom you have confidence that the mycobacteria is contributing to their symptoms or progression of disease in their lung. And so it's not the mere presence of the organism that would drive decisions to treat, but either progression of their symptoms that are not responsive to your other therapies, or if there are imaging changes that occur. And there are clearly patients who we can witness destructive changes in their airways, seeing cysts develop, cavities develop, um, despite the fact that there hasn't been substantial change in their symptoms, but what we would feel compelled to recommend treatment. So surveillance is clearly something to monitor. Again, also when those patients who you may have put on chronic macrolide therapy for the treatment of their frequent exacerbations, because you might want to make sure you're not seeing development of mycobacteria present in the airways. And some of these patients can change over time. And so here's an example who had grown Mycobacterium avium in sputum cultures, but had very few symptoms, did have changes on imaging, but 6 months later, you can see changes that actually were occurred where there's cavitation beginning to develop. And even though there had been no change in the symptoms of this particular patient, we felt that was evidence to suggest that intervention was warranted. Another reason why we might get subsequent imaging is to assess a response to treatment. Has there been a change, for example, in the nodule densities, cavities, or airway wall thickness? Here's an example of a patient with cystic fibrosis. Images were obtained before and after the initiation of CFTR modulators. These are novel therapies that have been out now for a few years that have essentially changed um, life for most of these patients with cystic fibrosis. And I think what you can appreciate here is a marked reduction in the mucus plugging and the airway wall thickening. There's still bronchiectasis, but the airways themselves look markedly improved. And this went along with the improvement in symptoms described by the patient. But we also monitor our response to therapy when we're treating mycobacterial infections. And what you can see here is a patient with a Mycobacterium avium complex infection and images before and after the initiation of antibiotic regimen. So I think you can appreciate the marked reduction in cavity sizes, mucus plugging, and airway wall thickness. This was an example of someone who responded beautifully to antibiotic therapy. The final reason why subsequent imaging might be helpful is in the acute setting and trying to figure out, how will imaging help you in understanding what to do for intervention.
What are the future directions for imaging of bronchiectasis? It would be ideal if we have to have repeat imaging that we keep in mind the lowest radiation dose possible. New MRI techniques are, I'm optimistic about them because they have no radiation and they can be done in a very short period of time. UTE and ZTE take 2.5 to 5 minutes to perform, and they can be done with the patient breathing and the machine tracking the breathing. So it's very comfortable for patients. You can see the good quality of the images we had done on a healthy volunteer. The takeaway points of our talks are bronchiectasis is irreversible airway dilatation with bronchus bigger than its accompanying artery. We need to differentiate traction bronchiectasis, which is caused by a disease of the lung itself, from intrinsic bronchial diseases. The pattern of the bronchial involvement narrows the differential, whether it is central or peripheral, whether it is focal or diffuse, whether it's upper lobe or lower lobe predominant. And we need to get the proper CT scan if we're going to do our best to make the correct diagnosis.